Okay, so today's topic, as I just mentioned, is about cancer screening. For us to understand what is cancer screening, we have to understand the concept of screening itself. So I'll have a small few introductory slides before we go into the topic per se on cancer screening. Now, cancer screening refers to a test or an examination performed on an asymptomatic individual. This is the key. So this is going to be done on an asymptomatic individual. It is not going to be talking about breast cancer, for example, breast cancer screening in a patient who comes in with a breast lump. No, that is not screening. Screening has to be done on a person who doesn't have any symptoms at all. So that is where we are going to do the cancer screening. The goal of cancer screening is to prevent death and suffering from the disease in question through some early therapeutic intervention. So the idea is you should have a disease which is screenable, should be where by doing the screening, we should find out the disease in an early stage or do something so that you can prevent the death or morbidity. So this is the idea of why we do the screening. There is no point in screening and finding a disease where you have no treatment, or by treating you don't give any advantage to the patient. So this is the important thing that you have to understand. And we classify the screening types based on whether they are opportunistic or programmatic. So opportunistic is, for example, a patient sees a healthcare provider who chooses to screen or not to screen. For example, a patient walks in, a lady comes to the gynecologist for some vague complaints. You may choose to give the patient the benefit of doing a screening mammogram. So that becomes an opportunistic screening. Programmatic refers to a standardized approach with algorithms for screening and follow-up, as well as recall of patients for regular routine screening. So this is a program schedule that you have. You have 100 patients listed with you based on their age and comorbidities. You call them at specific timings. So for a screening to be effective, it has to have, so this is sort of an MCQ. I thought I will just make a small MCQ to just keep people interested. So anybody will take this question for screening, which will be a true statement. Disease with a short clinical phase. A Will-Rogers phenomenon is due to stage migration. Overdiagnosis, an extreme form of lead term bias. And a screening test should have a high specificity. Anyone will be willing to take the question? Audience?
So I request all the attendees to post the answer in the chat box.
Yeah.
For Q&A session. Let's have an interactive session together. So we got one answer from Nitish Doctor, which is as C, overdiagnosed.
The true statement is overdiagnosis is an extreme form of lead time bias. That is the correct answer. Now we'll go on to why this is true. Okay. This is because screening is to be effective. You should have a disease with a long preclinical phase. Okay. That means you have enough time to do something that will stop the disease from manifesting. So for example, carcinoma in cervix. You have a disease, carcinoma cervix. You have a preclinical phase, which is carcinoma in situ. This is about a decade long. You have 10 years, that is quite a long preclinical phase. So that is the usefulness. So it has to be a disease where you will have a long clinical phase, preclinical phase. Will-Rogers phenomenon is due to stage migration. Will-Rogers phenomenon is because you're going to find cases earlier. That does not mean that the disease stage migrates. No, it doesn't migrate the stage. And the screening to be very effective, it needs to have a very sensitive test. You don't have a specific test for screening. Screening is something which will pick up large number of possible suspicious diseases, and it will not be a very confirmatory test. For example, if you take up HIV, human HIV disease, okay, the screening test will be an antigen antibody test, whereas a confirmatory test will be like a Western blot. You have 2 ELISAs going to be done. That will be a confirmatory test. So confirmatory test, you will need a high specificity, whereas for a screening, you will need a test which is more sensitive. Okay, we'll go on to the next slide, please. Okay, so what are the requirements of screening? For a screening, the disease burden has to be significant. That means the disease has to be a very common one. There is no point for screening a disease which is so very, very rare. Okay, for example, if you screen for a disease in India, which is not existent. For example, we talk about Ebola virus. Okay, Ebola virus is a infective virus, which is very deadly killer virus infection, which is very common in Africa. If you start screening for that sort of a disease in India, you're obviously not going to have a significant disease burden at all. In fact, it may be non-existent. So that defeats the purpose of screening. So the disease burden has to be significant. The natural history of the disease is such that a detectable preclinical phase exists. There is no point doing a test if there is no preclinical phase at all. If the manifestation is directly with the disease and there is no preclinical phase, then the screening may not be very effective. A test or procedure must detect the cancer earlier than if the cancer was detected as a result developing symptoms. For example, what we are trying to say is, suppose we have a screening test is a biopsy test. We cannot use biopsy as a screening test. Why? Because that will be a cancer detecting investigation and you will not be able to use it before the development of symptoms. So that is why you have to detect a cancer before the patient actually develops a symptom. And treatment should be initiated earlier as a consequence of screening, and this should result in an improved outcome. So the bottom line is this: by doing the testing on a significant disease burden, you're going to look at developing the test that will give a benefit to the patient. Now, whenever we use a screening test, people will always use some statistical terminology: sensitivity, specificity, positive predictive value, and a negative predictive value. So what are these? You have to understand them because this is the basis of how we do a screening test. So sensitivity is the proportion designated positive by the screening test among all individuals who have the disease. That will be ratio of total, that is the true positives compared to a combination of true positives and false negatives. For a screening test, sensitivity has to be very, very good, very high. Specificity is the proportion designated negative by the screening test among all those who do not have the disease. So true negatives divided by true negatives and false positives. Positive predictive value is the proportion of individuals with a positive test who will actually have the disease. It is true positives out of true positives plus false positives. And negative predictive value is the proportion of individuals with a negative test who do not have the disease. So that will be true negatives divided by sum of true negatives and false negatives. If you understand this slide, you will understand that a cancer screening test has to be more sensitive and less specific. Next slide, please. Lavanya? Yeah. So whenever we use the term screening, we have to talk in terms of these parameters. For a given screening test, sensitivity and specificity are inversely related. That means if you're using a sensitivity test which is very, very sensitive, a test which is very sensitive, then the specificity drops. Whereas if you use a specificity, very, very specific test, its sensitivity will drop. So this is the important thing that you will have to understand. You should have a degree test with, please go back. You need the test which has to be both highly sensitive and still specific enough that you will be able to do it. Positive predictive value and negative predictive value depend on the disease prevalence. So if the disease prevalence is very high, then the positive predictive value and negative predictive value will be of very good importance. And positive predictive value is highly responsive to small increases in specificity. So with this information in mind, we will go on to the cancer screening topic per se.